Good morning, and thank you very much for allowing me to present at the venous thrombosis meeting in Dublin 2023. My name is Gerry O'Sullivan. I'm a vascular and interventional radiologist. I specialize in deep vein thrombosis. Excuse me, pardon me. And I work in Galway in Ireland. And hopefully I can give you the benefit, or I suppose from all the mistakes I've made, hopefully I've learned how to treat patients with venous thrombosis better. When I was starting off in training, nobody was doing this. And I'm not saying by any manner or means that I'm a pioneer, but it was just that nobody else was doing much of this. I learned a bit in the States, and then I've kind of learned as I've gone along over the last 25 years how to do it, or how to try and do it a little bit better each time. And so now we're fortunate enough in Galway that we get patients from all over the world. And as with most medical procedures, but vascular procedures in particular, you've got to separate those patients. I can do the procedure, or most people can do the procedure the same way relatively well, but the trick is identifying those patients who are going to benefit from the procedure. And that's probably where I think, maybe because I've been sick a few times myself, I've learned to become a better listener, to really listen to what the patient is saying. And that's not something, I mean, they try and teach you in medical school, they really do, but I was probably too stupid, or I don't know, it took me a long time to get on the patient's wavelengths. And I'm not saying I do it every time at all now, but I try and get there quicker. And if you and your patient are on the same wavelength, then you've got a much easier road ahead of you, because you've got similar understandings of what you're hoping to achieve, where you want to get to, the limitations, and realistically, what can I achieve, here? And so if I have a patient who's not a good historian, that makes it much more difficult. And sometimes that's a cultural thing. Sometimes they don't understand what I'm trying to say. Sometimes it's because they're unable to give a good history, maybe due to a medical condition, and sometimes they're just not very precise. They're not really telling you how bad their leg is, and and if they're not able to communicate to me how it affects them in their life, then I'm probably not going to treat them. And that may sound cruel, but it's just been my experience. The major reason for that is that I find that if they're not able to tell me how their leg is affecting them, it tends to permeate through other things as well, so that they're probably not taking their medications as regularly as they would like, or as I would like. And anytime I do these procedures, the patient absolutely has to be on full anticoagulation before, during, and afterwards. So if the patient isn't able or willing to take their medication, then I'll probably stop right there. And obviously, if the patient is unable to use their leg, then it may not be worthwhile putting them through the risks of a certain procedure in order to improve the blood flow to or from their leg if they're not actually able to use that leg. Okay. What I found over the years is that most of these lesions, most of the deep vein thrombosis that I see, do have an underlying cause, a pinch point, or a lymph node, or a hernia, or sometimes a tumor, but usually just a narrowing in the vein, a compression point, what we call a iliac vein compression sometimes, or Mayfair. I'm fortunate in Galway that I've got an expert hematologist, in fact, expert team of hematologists, but one in particular, Ruth Gilmore, is really into venous thrombosis, and she knows that ins and outs really, really well. So these are two views of the Cliffs of Moher near where I grew up, and obviously they look quite different. And what I find from Ruth, I mean, I'm trying to put myself in the patient's shoes a lot of the time, and she's very good at taking a different history to what I'm taking. And between the two of us, then we kind of work out, well, this patient would really benefit from it, or this patient is probably hiding their symptoms because they're really afraid of me, which is fine. They're afraid maybe of the procedure not going well, or the procedure, or they're afraid of the risks, and that's fine. And, we will try and explain those to the very best of our ability. But if the patient isn't willing to give an accurate history, then it's more difficult. but having somebody to bounce ideas off is huge. And this is just an image of a CT scan, and it's not really important, but there's a very swollen left lower leg below this. And I specialize, sadly, at this stage of my life in left leg DVTs. So if I were looking for patients that I would like to treat with an acute deep vein thrombosis, those on the left are better than those on the right. Better, what do I mean by better? It means I'll get a better result for that patient in a more safe manner. So I mean, a lot of my patients are young, female, just out of the pill, come off an airplane, get a big DVT or a big DVT and a clot to their lungs, a pulmonary embolus. And if that patient was really active beforehand, or even just moderately active, living a normal lifestyle, able to walk to the shops or so on and so forth, that's a better patient to go after than somebody who's 85 years of age, who's got multiple other medical problems, because the patient, I can just treat the patient and get a better result. It's not about me getting the vein open. It's about how their leg is going to improve. And more importantly, how having a good leg is going to improve their life. That's the key. And that took me a long time to figure out. I spent a long time trying to make the veins open, and I got good at that. But then I eventually realized, well, having the vein open is no good if the patient isn't actually using their leg, or there's other medical problems that prevent them using their leg. So this is a classic story, and I only treated this guy a couple of years ago, and he's allowed me to use his photo, and it's a very nice name, a man by the name of Chris. And Chris is he's living outside of London, and he went off to Cuba to raise money, and it doesn't show it on that photo, but he's 6'5", and he's about 120 kilos, a big man, and he cycled in Cuba to raise money, and they got very hot, and this is him in Cuba. And then he got back on an economy flight back to Heathrow, 6'5", fitting into a 31-inch seat from Havana to Heathrow, got off the plane, collapsed. He was diagnosed with a massive pulmonary embolus. They didn't spot the fact that his legs were huge for a day or two, and he wasn't treated at all with any aggressive form of treatment, just put on anticoagulation. And that was in 2005, and I only saw him in 2020, just before COVID. And he had a variety of different treatments, and it was basically bandages to treat his problems. He saw a variety of different specialists, which is unfortunate, but maybe in a way, the traditional teaching has been that these patients don't do well, and therefore you're better off treating them conservatively. And so this is what his legs looked like, and he had ulcers. And his legs were black. The skin was black. I mean, he's Caucasian. He's from, I don't know, Birmingham, and he's as pale as I am. I guess white, is that what you call it nowadays? Not that it matters, but my point is that his skin was abnormally colored, and it was black. His words, not mine. But the skin was also really tense. He had these ulcers that were really painful and just miserable. And ulcer patients, like for those of you who are watching, if you're unfortunate enough to have them yourself, or if you know people who've got them, they're miserable because they ooze and they smell. And despite the very best one in the world, you're going to need multiple sets of sheets and multiple clothes and multiple socks and multiple compression stockings and multiple. And your legs feel tight no matter what you do. And you can't exercise. So therefore you put on weight, and it's very difficult. It's a really difficult quality of life. So these are just some images just to show you what we kind of do. This is images from below. And what you should see are two sort of clean pipes going up, because I'm injecting at the level of his groin here. He's fast asleep. And you don't see that at all. And to cut a long story short, we got across this, we ballooned it, we made the balloons bigger, we put in some stents, and there's our stents going in, and they're in front of the vertebral body. And this is what he looks like at the end of the procedure. And there's a nice, good flow going up north, just like that. And everything's happy from that point of view. And then critically, this is what his legs look like after 6 weeks. So he healed his ulcers in 6 weeks. And this has been my experience, that people heal their ulcers in 6 weeks. I had a man in 2016, and he had had ulcers since 1978. A really nice man. And his life was just miserable, and I was humbled. He was so patient, and he had seen so many doctors, and they'd kind of blown him off for years and years and years, you know. Anyway, he healed in 6 weeks, and we might have gone for a few pints after that. You never know. These are other patients, and it's not that I'm into showing patients' legs, but I suppose, well, as they say, a picture is worth 1,000 words. It's hard to describe what this means to a patient if their legs come back to normal size and they're able to walk normally. And this lovely, lovely old gentleman, and he gave me permission. He's got colostomy, he's got cancer. His leg was so tight, it was like a drum, you know. And that was after just 2 days. Just 2 days later, it got better. And that's not because of any kind of magic that I do, but the technology now is really, really good. And I suppose the biggest thing is that because we've got a name for getting sent these patients, we get sent these patients, and there's stuff we can usually do. And so sadly, I've ended up devoting my life to this. And I don't know, these papers are a few years out of date now. I've got a few since then, but I really, really am into DVT, and I hope that sometimes the patients we treat improve a lot. If you're having trouble sleeping at night, you want to learn a bit more, this is a book we edited a few years ago. And thank you very much for your time.